Okay, last but not least, we did an initial dive into concepts of pain and pain management. Again, y'all, this is like a real quick Cliff Notes. We will discuss pain at multiple points throughout the program here, but for this particular video, I'm not going to go super in depth. Pain is a very complex, obviously complex phenomenon consideration when we're talking about rehabilitation. So there's a lot to unpack, but we can't unpack all that in the nature of this video. So I'm going to stick to key talking points here. But just, don't be dismayed. If you don't have a working understanding of some of these concepts just yet, it's all good. We'll get there, I promise. All right. So, learning objectives. Pain. Why is pain important? Because pretty much all of our patients are going to come to see us because of pain. What is pain? Unpleasant sensory or emotional experience associated with actual or potential tissue damage. And pain, first and foremost, is an output of the brain. Until the pain is interpreted by the brain, the pain isn't actually necessarily real in the perspective, from the perspective that we would think of pain being real. All right, key terms. Know the key terms in their definition. We'll talk a lot about these. Nociceptors, sensory receptors for painful stimuli. So you see nociceptors, you think pain. Peripheral sensitization, we'll talk about central sensitization. Primary and secondary hyperalgesia. Hyperalgesia is a term that you will use, which is a condition where hyper or overactive algesia pain, the pain intensity that's experienced is not proportional to the stimulus. So it's an exaggerated pain. Allodynia is a stimulus that's going to produce sensation, not pain. But unfortunately, what will happen is these will get confused. So with a condition like allodynia, a normalized sensation that or stimulus that should produce simply sensation should not produce pain, but it does. Okay, so that's again another faulty phenomenon. And then fight or flight response with the sympathetic nervous system we'll discuss. Again, nociceptors are receptors that are going to produce action potentials that are there to transmit and receive painful stimulus. So they're activated by things like intense thermal, mechanical, or chemical stimuli, right? Thermal, I touch the hot stove, I cut myself with a knife, right? Mechanical, chemical, same thing, right? So these are all stimulators that can produce painful responses. And when they're activated, they're going to produce what's called an action potential or potential for action. Peripheral sensitization is going to allow, and this is something we'll talk about a little bit too, non-noxious stimuli to trigger nociceptive input. So again, this is like an allodynia where you have this non-noxious stimuli triggering painful input, even though it's not supposed to. How is pain? What are the nociceptors, and how is pain transmitted, received, and transmitted through the body? Well, they're transmitted through peripheral pathways, and the primary transmitters or conductors of this information are going to be the A delta fibers, which are small myelinated, and C fibers, which are also small but unmyelinated. So definitely know the difference, right, between your A fibers, your A delta fibers, and your C fibers. Know some of these fundamental characteristics. For instance, A delta fibers are responsible for responding to intense mechanical stimulation. And when we say intense or acute, these sensations are sharp, stabbing, or pricking. These are not blocked by opioids. With C fibers, right, the sensations are going to be tend to be more chronic feeling in nature, right? Dull, throbbing, aching, burning, tingling. It's a slow onset, long lasting, sort of diffusely localized type of pain projection that is typically, because of its constant input, going to be accompanied by sweating, increased heart rate, and blood pressure because of centralization at the level of the brain and the spinal cord. So these C fibers as well are the fibers that are blocked with opioid medication. So here is just a diagram, a depiction of your ascending neural pathways for A delta and C fibers to the spinal cord and the brain. Again, we call these afferent pathways, means they're heading to the brain, hopefully to elicit an efferent response, which would be motor. Your afferent pathways, right, will come in through the dorsal horn, the backside, enter the spinal cord, and depending on gait control, potentially be could conducted or delivered to the brain via the spinal cord. With these, we'll discuss this a little bit, but here you can see C fibers, unmyelinated, slow chronic pain, A delta fibers, myelinated, fast acute pain. Peripheral pathways also include what's known as A beta fibers. So I want you to make the differentiation here. These two are peripheral pathway fibers that are nociceptive in nature, right? They're meant to receive and transmit painful stimulus. An A beta fiber are non-painful sensations, right? Or they are structures dedicated towards receiving and transmitting information about non-painful sensations related to vibration, stretching, and mechanical pressure. They also, again, as noted with earlier in the lecture, and we'll talk about later, can be involved in abnormal prolonged pain perception. So they can almost unduly be recruited to transmit painful stimulation, even though that is not their primary job. They're not nociceptive in nature. They're non-nociceptive receivers. Pain quality, again, depends on the type of peripheral nerve activated, but also what kind of tissue you're talking about. So we know that we have these primary differences between our peripheral pathways that are giving us painful information. We have an A delta fiber and a C fiber, right? A delta is going to give us acute pain information. It's going to be transmitted very quickly. And part of the reason it's transmitted so quickly is because these A delta fibers are myelinated, right? You can think about this as a wire that has conduit surrounding it, right? The conduit helps to insulate the wire, and because of that myelination, it's able to more effectively and productively transmit information signaling to either just to the gate control, right, to the interneuron, or beyond to the brain and spinal cord. This results in a faster delivery of pain and also shapes a little bit in terms of what the pain experience is like, that sharp, right, stabbing kind of pain, where you can see here a vast distinction between the unmyelinated C fibers in terms of how quickly or relatively slowly they transmit that information. And because of that, it's going to translate into a dull, aching, or chronic pain pathway or sensation of pain. Central pathways, once we move from the peripheral pathways, right, where we have our central pathways, which are primarily delivered via the spinal cord. So the peripheral nerves project to the dorsal horn gray matter here. They meet at the spinal cord through the interneuron, which is here. And at the level of the interneuron, again, this is important because interneurons are subject to a phenomenon called pain gating, which we'll talk about. And pain gating, or the gate control theory, is why physical agents are thought to control pain. So we'll discuss that in a second. So here's the gate control theory. It's going to state that nociceptive signals can be inhibited at the spinal cord level or the interneuron by non-nociceptive input. So what does that mean? It says that we have nociceptive or pain signals and non-nociceptive, which are pressure, mechanical signals, vibration, things like that. When the two go head to head, they can be inhibited at the level of the spinal cord at the interneuron and prevented from reaching the brain, the perception of the brain. So I hit my thumb with a hammer. The first thing I do is I grab it, I hold it. That's the body's instinctual way of saying, let's introduce some non-nociceptive input to block the nociceptive signals at the interneuron and prevent that pain from being transmitted to the brain. That's why it feels better if you hit your knee, bump your knee, and you rub it, right, immediately. It's also part of the reason they say, oh, rub some dirt on it, right? It's not so much that the dirt is good for you. It's more or less that you're rubbing it. A dog or a cat sustains an injury. What do? They start to lick it. Most of that has to do with varying things, but part of it is gate control. So again, here's the important thing. Gate control is important because most of the modalities we're going to talk about in this class are thought to control pain by supplying non-nociceptive input to sensory nerves by closing the gate at the spinal cord level. It's good because once it's in the brain, once you've woken up the big boss and said, hey, the brain, we got something we got to respond to, you're going to get a 3-alarm sort of response, right? It's not just going to be segmented into certain systems, or into certain system silos. The whole body is going to respond to the pain. So you'll get a 3-system response, which will include sensory, motor, and limbic system reactions, right? So we don't want to just wake up the brain for no good reason. So here's our example: 2 gate control. You're a kid, you're riding your bike, right? You fall off the bike, it hurts, right? You got a boo boo, you cry. Your mom comes over, she gives you a hug, right? She gives you some compression. She rubs the site of the injury. She kisses the boo boo. But what she's really doing is flooding the spinal cord with non nociceptive stimulation to close the gate at the interneuron and relieve some of the perceived pain. Referred pain is interesting in the sense that it's pain that is experienced, and you should know this definition, experienced in one area where when the actual tissue damage has occurred in another area. So you can have referred pain sensations at different parts of the body, even though those parts aren't necessarily impacted by any structural or physical damage. And so we know those as referred pain. So here's our spinal cord modulation. Again, the gate control theory is also telling us that it's not an all or none response, right? So we know we can impact the amount of pain perceived or allowed to transmit to the brain through the gate control theory, but we can also impact the pain severity based on how much of that input, either excitatory or inhibitory input, is allowed in the spinal cord, right? And that reaches the brain. So it's not like we close the gate control and no pain can be perceived whatsoever. I think we know that, right? But we can lessen the amount of excitatory inputs that are perceived by the brain and increase the amount of inhibitory inputs to modulate the perception of pain at the spinal cord and in the brain. So nociceptive signals can be inhibited at the spinal cord by an increase in non-nociceptive inputs. That's the gate control theory as a whole. And again, if you haven't noticed this already, this is like the third time we talked about it. Most of your physical agents are thought to close the gate by supplying non-nociceptive input. So that's the name of the game when we talk about pain and modality use. There is an endogenous opioid system. We won't get into specifics, but there are endorphins that are released and can control pain by binding to certain opioid receptors in the body. Okay? So there are protein receptors that we have that are part of the endogenous opioid system. We won't discuss these in great detail, but just understanding that controlling pain within the body can be conducted by the release of endorphins that will bind to these receptors throughout the peripheral and central nervous system. So we release certain endogenous opioid receiving endorphins. The two pair up together. Endorphins are released. They bind to these specific receptors for certain opioids. And the result is we can have a number of different things happen. We can have regulation of pain levels. We can also have inputs and outputs in terms of regulation of emotion, response to stress, motivation, and drug addiction, which sounds a lot like what you see in abuse of opioids, right? But this is all happening in the body naturally. So for an example, a mu receptor is a receptor that is acted upon by morphine. So morphine binds to the mu receptor. Unfortunately, so does heroin. So the effects that we get that we know of, right, some of the analgesic effects, some of the other effects that we get from morphine use are because of its binding to these mu receptors within the body. Unfortunately, if you have an excess of these, you can end up affecting the systems in a heightened way. And strangely enough, heroin also affects the mu receptors. So we discussed this in class a little bit. I'll let you go back to that and lecture and think about some of the things we talked about. But these delta receptors seem to affect mood, especially post mu receptor enhancement or crash, right? So this is part of the reason why some of these drugs are so difficult to taper off, so difficult to withdraw from. Central sensitization is going to be a facilitation of nociceptive impulses in the CNS. So once we have central sensitization, you have a facilitation of transmission of this information in the spinal cord. You have an inhibition of the endogenous opioid system, and you end up with an altered processing of nociception in the brain. So nociception encodes noxious stimulus. So again, nociception has to do with painful stimulation. But what happens with central sensitization is this is a phenomenon that's abnormal, where you have enough continued input and facilitation of these pain responses within the central nervous system that you can start to have a faulty, almost a faulty reporting of pain within the body. So the body's perception of pain doesn't fit a normal or typical anatomical or neurological distribution. So what does that mean? It means that the pain can continue on as a central sensitization or a central nervous system process with no continued ongoing peripheral input, right? So it means that the pain is still being experienced by the person and the pain signaling is still occurring, even though the physical or peripheral damage that initially caused the pain is no longer occurring, right? So the injury is over, it's healed maximally. However, we're still having this input of pain that's not tied into any kind of peripheral damage or physical or structural damage. So there's a book example. Your car alarm is going off. The alarm itself is very real. We can hear it, right? We can respond to it, but nobody's out there trying to steal your car. So pain modulation and control. Within the pain matrix, we're going to have sensory, motor, and limbic systems all included from the brain. So this is going to give us three distinct outputs. It should be three. Conscious perception of the pain is first. We're going to become conscious of the perception of the pain once it reaches the brain. Then we're going to have some kind of physical action and or motor response from an efferent signal, right? Motor response, which is going to say, hey, I'm conscious of the pain. The pain, I've got my hand on the stove. The peripheral pathway comes up. It centralizes. It says that the information is passed through to the spinal cord, past the gate control, is perceived by the brain, becomes conscious in its perception of pain. The brain says, oh my gosh, that thing is hot. First thing we got to do is move the hand so no further damage is incurred. Right? So then you have an efferent motor response that creates a physical action to move the hand. And then you have activation of our homeostatic systems, which would be the autonomic nervous system, immune system, endocrine system. Again, when the brain responds, it responds in a big way. This can also include sympathetic nervous system influences like your fight or flight response. So, what types of pain do we have? We'll keep this from going too long. Know the difference fundamentally between acute pain and chronic pain. Some of the diagnoses associated with each. Again, these are timeline sort of placeholders. Not everyone's going to be like this, but for purposes of us learning, at least initially, these concepts, we'll stick to that. So, types of pain, again, a normalized pain response is a nociceptive response. Know these types of pain for sure for your quiz. Has a clear stimulus response relationship with the initial injury, right? It can be felt at or around the site or referred pain, but you have something wrong, there's a normalized response. That's information is transmitted by your peripheral pathway signals, sensory signals, your nociceptive signals, interpreted by the brain, and we have a normalized response to that stimulus. Neuropathic pain is going to be pain that is associated with typically a nerve pathway. And so typically associated or accompanied by signs or symptoms of some neurological dysfunction. So it could be a paresthesis of some kind, could be itching, anesthesia, right? Loss of feeling, weakness, muscular atrophy, things like this. Neuropathic is often described as a shooting pain that's running down a nerve track, right, which is usually the product of a compression of the nerve, sometimes maybe at a discal level, or stretching of the nerves, which is going to lead to some degree of neuralgia. The more you compress or stretch the nerve, the greater the pain gets, and usually the farther down the nerve track it will run. Central sensitization, just a key note here, is worsened by cold, something to consider. And allodynia, again, a nonsensical light touch pain, and hyperalgesia, the intensity is unproportional to the stimulus. So those two conditions are components of central sensitization. Again, this is a faulty response by the central nervous system where interpretations of pain become markedly, to some degree, they're impacted in a nonsensical or non-normalized way. Right, so we have a processing of pain that is abnormal. Either we now have pain that's going on to some degree with, again, centralization, that car alarm example, right? Pain that's going on without any further peripheral input. We can also have overreactions by the nervous system to recruit those A beta responses that are going to give us nonsensical pain to stimulation that shouldn't be painful, right? So non-nociceptive inputs are creating nociceptive responses. I touch you on the outside of your forearm, and that shouldn't cause pain, but it does. Hyperalgesia, again, the ratio between the what could be the painful stimulus and the pain response is not equivalent, right? Or not normally equivalated. Psychosocial pain as well. Pain where psychological processes are playing a large role. You've heard this maybe as psychosomatic pain to some degree. Again, these are typical descriptions of pain that I would know. Skin surface pain is usually sharp, prickly, or tingling. Musculoskeletal pain is going to be described as either dull, heavy, almost like toothache pain. Visceral pain is going to be a lot like musculoskeletal pain in its presentation, except it's usually going to wax and wane, and it will refer superficially and not so much deep. And here are our pain assessments. We talked about these in tests and measures. Go back and review. Make sure you know each one of these examples of the visual analog scale, the FACES scale, the McGill pain questionnaire, body diagrams, again, using a legend to be able to physically draw on the body where you're experiencing the pain, the types of pain you're experiencing. Again, pain management, understanding the goals of pain management and how it's treated from a multidisciplinary approach. Some of the physical agents that we can implement that we'll learn through the course of this course. We'll figure out what physical agents we're going to use for modulation or influencing pain. Here are a few examples we'll talk more about. You don't need to know the pharmacological approaches. Just understand some of the standard systemic analgesics like your NSAIDs, acetaminophen, opioids, etc. Right. These are big, right? One thing to remember here, common side effects for opioid effects are all these listed again. The most dangerous of these side effects can be respiratory suppression. Respiratory suppression is what we want to pay attention to, right? Obviously, tolerance, dependence, and addiction are ways that we need to advocate for our patients if we're seeing things that we find to be concerning. But when you think of some of the opioid side effects in terms of rehabilitation and treating a patient in real time, respiratory suppression is going to be a number one. All right. Exercise, again, how exercise is going to affect the pain. These are comprehensive pain management programs. And that's pretty much it. So again, we breezed through that pretty quick. We have, 20, that was like 20 minutes on pain. You could do endless talks about pain in particular, and we will go into greater detail on that. But just for a rundown for your week ahead and looking back at the week from behind, just to review what we talked about, that's all we need to know for the purposes of that. So that should cover everything for week 1 and help you a lot in your prep for your quiz. Hope you guys have a good holiday weekend, and I will see you next week.